Picture a major stroke, the kind where a big vessel in the brain is blocked, and the fix is to physically pull the clot out. The paramedics arrive, run their checks, load you up, and then drive right past the hospital 5 minutes down the road to one that's half an hour away. It feels like a mistake. It isn't. It might be the single most important decision anyone makes for you that day. Because here's the thing, almost no one realizes about emergency care. Not every emergency room can treat every emergency. And when minutes decide whether you walk out or you don't, the paramedics aren't aiming for the closest hospital, they're aiming for the right one. Start with the uncomfortable truth. Every emergency room in America can take anyone who comes through the door. That's the law, but being able to see you isn't the same as being able to fix you. The community hospital down the street can diagnose a stroke, but it may have no specialist who can physically pull the clot out of your brain. It can spot a heart attack on an EKG, but it may have no cardiac lab to open the blocked artery. A hospital isn't one thing, it's a ladder of capabilities, and the paramedics are trained to know exactly which rung each hospital is on. So let's answer it like an operator. Why would an ambulance ever skip the closest hospital? Because emergency care is regionalized, deliberately organized so the sickest patients are routed to a small number of highly equipped centers, even if that means a longer drive. It's a system built around one hard trade, a few extra minutes on the road, in exchange for a hospital that can actually save you. Let's walk the ladder. Here's why the minutes matter so much. In an untreated stroke, the brain is dying fast. By one widely cited estimate, roughly 1.9 million neurons, brain cells, are lost every single minute the blockage sits there. 2 minutes of extra transport can be worth it if it means arriving somewhere that can actually clear the clot, instead of somewhere that can only stabilize you and then send you on. Doctors have a phrase for it. Time is brain, and the same logic, every minute counts, drives how ambulances route heart attacks and major trauma too. So there's a trade-off baked into every serious call. Your instinct, and it's a reasonable one, is that the nearest hospital is the fastest care. But speed to the wrong hospital can be slower than a longer drive to the right one, once you count the time lost transferring you afterward. The paramedics are running a different calculation, not which hospital is closest, but which one can give you the definitive treatment your emergency needs. Closest versus capable. And for the sickest patients, capable usually wins. Because a hospital isn't one capability, it's several, each certified separately. There are trauma centers for major injury and the surgery it needs. Stroke centers, tiered by whether they can remove a clot. Cardiac centers with the lab to open a blocked artery. Burn centers, and centers for high-risk newborns. A given hospital might be a top-tier heart center, but not a trauma center at all. So the question is never just, where's the nearest ER? It's where's the nearest ER that does this. Take the most developed example, trauma. It's the clearest picture of how this ladder actually works. Trauma centers are graded into levels. The American College of Surgeons verifies them, and states run their own designation on top, so the exact rules, and even which levels exist, vary from place to place. Broadly, a level 1 is the top, trauma surgeons in the building around the clock, the full range of specialists, a dedicated trauma ICU. A level 2 is close behind in what it can do. A level 3 can stabilize you and handle some surgery, but sends the worst cases onward. And level 4s and 5s, often the only hospital for miles in rural areas, are built to stabilize you and transfer. So a bad car crash doesn't go to the nearest ER, it goes to the nearest one equipped to operate. There's a catch though, and it's geography. In an older national study, about 95% of city residents could reach a top-tier trauma center within an hour. In rural America, only about 24% could. That gap is the hard edge of regionalization. Concentrating the best care in fewer places makes it excellent where it exists, and far away where it doesn't. For a lot of rural patients, driving past the nearest hospital to the right one simply isn't an option. The protocols know that and build in fallbacks. And when the ladder does reach you, it matters. A landmark 2006 study followed thousands of seriously injured patients and found that those treated at a level 1 trauma center had roughly a 25% lower risk of dying than similar patients treated at hospitals without trauma capability. Now, that's one study from one era, and trauma care has evolved since. But the direction is the whole reason the system exists. The right hospital isn't a luxury. For the sickest patients, it's the difference. Stroke works the same way. At the bottom of the ladder, an acute stroke-ready hospital can give clot-busting drugs. A primary stroke center has a full stroke unit. But the top two tiers, thrombectomy-capable and comprehensive centers, are the ones with the team that can thread a catheter into your brain and physically pull the clot out. For a big stroke, that can be the difference between recovering and not. So a suspected major stroke gets routed, when it can, straight to one of those. Though protocols weigh that against getting clot-busting drugs sooner at a closer hospital. It's a real trade-off, not automatic. And there aren't many of them. In a 2022 inventory of more than 5,500 emergency departments, just 311 carried the top two stroke certifications, the tiers recognized for removing a clot. A handful of others may do the procedure without holding that exact badge, but the certified map is the one the ambulances route by. And for a major stroke, that map is suddenly very small. The nearest ER and the nearest clot removal center are often not the same place. Heart attacks follow the same rule. For the most severe kind, a fully blocked artery, the fix is to physically reopen it in a cardiac catheterization lab, and the national standard is to do it within 90 minutes of arrival. Only hospitals with that lab, staffed and ready, can hit it, so paramedics run an EKG in the ambulance, and if they see that pattern, they radio ahead and drive straight to a cath lab hospital. Because stopping at a closer one without the lab just burns the 90-minute clock on a transfer. So who's actually deciding all this in the back of a moving ambulance in a few minutes? Not a guess, a protocol. For trauma, there's a national field triage guideline, a decision tree paramedics run in order, put into practice through each region's own local protocols. First, are your vital signs failing? Then, is there a severe injury pattern, like penetrating wounds or multiple fractures? Then, was the mechanism violent, a big fall, a high-speed crash, even if you look okay? And finally, special factors, your age, blood thinners, pregnancy. Trip the most serious steps, failing vitals, a severe injury, and the rule points to the highest level trauma center you can reach, past the closer, lower level ones. Trip a lower step, like mechanism alone, and you may go to a capable but not top-level center. Stroke and heart attack have their own versions of the same tree. So that's the bet the whole system makes on your behalf before you can even weigh in. A few more minutes in the ambulance, in exchange for arriving somewhere that can give you the treatment your emergency actually needs. One crucial caveat. This logic is about the ambulance, where paramedics are treating and monitoring you the entire way. If you're driving yourself, the math flips. Get to the nearest emergency room fast and let them stabilize you and arrange any transfer. The bypass only works with a trained crew keeping you alive en route. For a sprained ankle, none of this applies. For a major stroke, a severe crash, or a massive heart attack, it's the difference between a good hospital and the right one. That's capability routing. The system working as designed. But there's a second reason an ambulance might pass a hospital. And this one isn't the system working, it's the system breaking. It's called diversion, or going on bypass. When an emergency room gets so overcrowded, often because it's holding admitted patients it can't move upstairs, the boarding problem, it can temporarily tell incoming ambulances to go somewhere else. And this has nothing to do with capability. A hospital perfectly equipped to treat you turns you away simply because it's full. Capability routing sends you to the right hospital on purpose. Diversion sends you away from one that was right, by accident. They look identical from the sidewalk. They are opposites. And it's common. In one older CDC survey, about a third of American hospitals went on diversion at some point in a single year. Big city ERs, hundreds of hours annually. And it's not harmless. One California study found that heart attack patients whose local ER spent long stretches on diversion were measurably more likely to die within a year. It got bad enough that Massachusetts banned the practice outright, and, tellingly, hospitals there adapted by fixing their patient flow instead. Diversion isn't a routing decision, it's a symptom of the crowding we covered in earlier episodes. So put it together. An ambulance drives past the nearest hospital because not every emergency room can do everything. Because the sickest patients, trauma, stroke, the worst heart attacks, are deliberately routed to the few centers that can give them definitive care. And because when minutes decide the outcome, a longer drive to the right place beats a short one to the wrong place. That's the system working. The version to worry about is the other one. An ambulance turned away from a hospital that could have helped simply because it was too full to take you. If you want the operator's view of how healthcare actually works, the systems behind the headlines in plain English, the breakdowns are at shanewelter.com/free. Next question in this series. Why does the pharmacy always seem to be out of some ordinary decades-old drug, the cheap, basic stuff hospitals use every day? The answer is a supply chain quietly running with almost no slack.